Okay, we're going to do the posterolateral approach followed by the direct lateral approach. And so this is the system from Zivation. You can tell by the bright red. And the start point on this will just be lateral to the PSIS at the level of S1. And I will put in a S1 portion, and we will save the S2 for the lateral approach. So start point, again, will be pull toward you. Just lateral to the PS, pull toward you. Yeah, good. At the level of S1. And so this will be, start point will be just medial to the gluteal muscles. Okay. All right, and let's go to an inlet view. So right here. And let's see what that looks like. So a little bit more caudal. And yeah, that's good. Let's look up north. Okay. All right, so this will be able to get our trajectory, and we are going across the joint, and we're going to aim toward the center of that sacroiliac. And this is a very good trajectory. This is going to place us just oblique, and this is, you'll note that this is almost perpendicular to the SI joint. And this is a good trajectory. Let's come back to the outlet view here. And we know from a combination of the outlet view that lays the sacrum out on FOSS, and the combination, let's take it south a little bit, that's good. That's it right here. Yes, no, here, outlet view, please. And we'll need to go south. More. And right, we're actually aiming toward the pedicle of S1, which is very good. And so we'll just aim inferior to that just a little bit, and we're not going to change our dorsal or ventral at all. So that's pretty good. Let's take a lateral view, please. And so once we get this in place, we'll put the Steinman pin in, and then we'll measure the size and determine that. I'm going to put these screws for Zivation come in two sizes, 11 and 12 and a half, and I'm going to put a 12 and a half in. So it's very good. Just pat, we're still in the sacroiliac. It's about right. I'm going to pull this back just a smidge, and there we go. So take the wire, let's come back and take an inlet view here. An inlet view, all the way caudal. So that's very good, it's going toward the sacral body, and we're still in the ala. Let's come north. We don't need to go that far. And then we come, let's look north. Good. So that's about right, perpendicular to the joint. And we will take the cannula out, and we'll put the dilator in over that single dilator piece here. Okay. And we will put this in, and it has proximal threads on it to be able to size. I'm going to cut down a little bit so the dilator will go down more easily. Okay. All right. And we'll measure this out. Let's about a 45. The hardest part of this whole procedure is reading the small numbers. It's a great challenge to your presbyopia. So the working channel over the top of this is made of a radiolucent peak. I'm just going to fit that down over the top of this, and we will take the internal dilator out. And over this, we'll see that this is the inserter we have here, and the inserter we have here, and the screw, this is 12.5 by 45. This fits over the Steinman pin.
Doug, that's a dual pitch screw, is it not?
It is. It's the pitch is not much in terms of differential, but it does have a lagging capability because there's the threads distal and there's threads proximal. So we can kind of see it here, and it has a ratcheting mechanism. We can see it advance into the sacrum. And you can always feel when you get close to the SI joint, because this thing it's very hard, especially if in contrast with the fairly osteoporotic ilium and sacrum, especially the sacrum. If you're going to have one area of the sacrum that's osteoporotic, it's going to be in the the ala of S1. And we can see it kind of go down. We can see it become almost flush. The back end, the goal for this is for it to become flush with the posterior portion of the ilium, and I can feel it tighten up because there's a flange there. And so let's take an outlet view here. And again, this is a pelvic inlet view. And we have the non-threaded portion overlying the SI joint. And so let's take the whole thing down. Good. Let's arc a little bit toward me. And go ahead and, arc a little bit toward me. Mm-hmm. That's good, right there. That should be a direct AP shot right there. We kind of like the look of that. I'm going to go ahead and detach this. Pull the handle off approximately. Out comes the wire, and then I'm going to detach this from the screw. And let's take a lateral shot there. We'll save that as an AP shot here. Okay, let's take a lateral picture of that. Yes, please. And let's move it north a little bit. Yep. Very good. Like that. And that is the S1 approach. And you can see we're off a little bit, but at least our side, the sacral ala, the line is just above that. We are a little bit off on the obliquity, but that's a very nice shot. Okay, posterolateral approach. Questions, comments? Let's go back.
On the back table, if you need to, do you load that with bone graft extender or BMP or whatever your choice?
Right, so I don't load this at all. This screw has certain features, one of which is self-augering. So this pulls graft into as you place it through the ilium. And my thought on that is the best graft material that there is, that exists, is the ilium bone marrow. And so this has a self-tapping. It will lag based on the feature of the screw that's between the threads that you place over the joint. It has a flange on the proximal portion, so it will secure itself as it continues to pull the sacrum forward and pull it together. And it's rifled on the inside. It goes over the Steinman pin very easily. So these are well-engineered screws.
And you get a lag effect from it, so it's a compressive arthrodesis instead of a distractive.
Yeah, exactly the opposite of some of the things that we've talked about. But this is that's a very nice, well-placed S1 posterolateral screw. So with that, I say thanks to Andy Foster, really appreciate it, from Zivation. Thank you guys, and we will move on to the lateral approach. And so I'm going to mark this, and we'll do, I'll tell you what, we'll do an S2 screw. Typically, I'll do 3 screws. I always do 3 screws based on the Joe card paper. Let's go lateral, please. And that is a meta-analysis of 55 different articles that says definitely 2, probably 3 is the right number of fixation points for SI joint fusion to make it biomechanically optimal. And so I will take the probably 3 for me to mean every time I will put in 3 if possible. All right, so I'm going to show you the S1. I'm just going to give you a trajectory.
We're not seeing the view. There we go.
Okay. I'm just going to kind of line the trajectory out. I usually line the trajectory out because the direct superior is very different than the superior according to the sacrum itself. And so let's pick S2. So this is about S2 right here. So I'm going to make a little incision over that. So we see S1 and we see S2, and I'm going to go just below the TFX that is actually on the opposite side, but this is something that we will go just inferior to that. So small movements on the side of the ilium equate to fairly large movements on the II. And again, I'll use rigid access for this. I like the rigid access. I think it provides a lot of protection, and I think it provides a lot of ease of access. It's also very predictable. So I'll go a little bit here. So this is right at S2, and we're going to confirm that's right at S2 before we get to any place that's comes close to a foramen. So this is right in the middle of S2. That's where the tip is. So let's come back around, and we'll take an outlet view, background outlet view. So we'll typically put 1 at S1 down the bone corridor, 1 at S2, also down the bone corridor, and then we'll put a foraminal screw or a second S1 screw. We'll see where we are with this. Good. So can we move a little south? So this is good. We see the S1 neural foramen, and we're going between that and the S2 neural foramen, which is very difficult to see on this, but we'll just stop short of where the projected S2 foramen is, so we won't even worry about it. All right. Okay, so I'm going to take the stylet out, and we'll use the short wire right here, and then we'll use this to size. And so this goes in, and I can kind of feel the bone all the way across, and this will probably be it will probably be in the sacral body, the tip of this, because I can feel it right there. The bone becomes harder. I can feel the crunch of it. I can feel it going all the way across. And let's take a pelvic inlet view, please.
Yeah, the S2 foramen is not blatantly obvious.
No, you can't really see it. I'm extrapolating, and I can feel the cancellous bone as I go through there.
Is there another term for extrapolation?
Say again, Neil.
Is there another term for extrapolation?
Guess.
Kentucky windage?
I'm guessing. And so we could come, I want to go a little bit posterior. And so I'm going to change the trajectory here and go a little bit posterior. And I could feel the bone become hard right there. And so that's a very good trajectory. So I'm going to take this out and I'll put the dilator 1, and that's where we'll get our size. Let's go back to the outlet view. And we'll put these two wires, Steinman pins together. This is reverse thread, so it's lefty tighty. Let's go south. Okay. And I'm going to put a screw in that's about right there. And this is going to be, that's a 40, so let's do 11.5 by 40. And so I'll place dilator 2 plus the working channel. And then after the working channel is in place, I'll take the inner dilators out and place this over the Steinman pin. Oh boy. Boy, lost access there. Okay. Let's swing it back lateral for a second. We swing it back lateral. That's fine. Raise it up a bit. So drop it down again. Okay, that's good. All right, come back around to the outlet view. Thank you. All right. So again, this is a ratcheted mechanism. We'll watch it go in on the outlet view. Go ahead and let that go like that, yeah. All right, so you can feel it go. It's advancing nicely. Good. Let's take an inlet view. That's good, not quite that far.
You can readily see the different pitches on the two screw threads. They're different pitches, and that's what causes the compression.
Come up.
The pitch in the sacrum has wider spacing between the teeth. It pulls more.
Good.
On the ilium, it has tighter spacing between the threads. Yeah, there you can see it.
All right, good. So see it come across. Back around to the outlet view. Let's go south. All right. I'm going to continue to advance.
We are not centered on the X-ray. We are too proximal, seeing lumbar spine. Yeah, the screw is barely on our field. Have to move distal.
So let's go south, please.
There you go.
That's fine. Okay, and the distal part of where we'll be, we can start to see the foramina there, so it looks like it's between the S1 and S2. Arc toward you 15 degrees, and so we'll get the back part of the ilium by doing an ipsilateral oblique. That's good. So we can start to see the back part of the ilium, and we can see that's flush. We can now see the S2 foramen, and we'll just get that flush against the back part. It's a very nice view there. And we will disconnect. And the wire comes out. And there we get an ipsilateral oblique of an S2 screw would flush up against the posterior portion of the ilium. So that's the Genesis screw. The screw for this is similar features. It has the added features being textured. It's 3D printed, and it has lagging capability. You can see the threads on the front part of the screw are wider in pitch than the threads on the back part. So it advances more proportionally per turn than the screws do on the posterior portion. That creates a lagging feature and lags and draws the sacrum close to the ilium. So that's a lateral approach by Genesis. Thanks, Dave Jones and company. And that's it. And Gary.
Yes.
Any questions? I might just throw one in the kitty. In orthopedics, we've learned that anything we can screw in, we can screw up. So when you're looking at the sacroiliac fixation screws that were previously shown, do there exist revision screws should you have over-tightened the screws into the ilium or sacrum, particularly the sacrum, and strip them?
Yeah, so there are various things that you can do. So if these screws, if you strip and they become loose in the bone, there's a few different things that you can do. One is you could remove the screw using the distraction kit. And so it's the same as the inserter, except it has a longer thread portion. So if you strip putting in, you could take the distraction device, and it's like a little anteater. It has a longer throw that goes inside the screw and is able to access farther in, so you can tighten it down and then take the screw out and then put a longer one in if you want to revise it. If it's loose, you can 90%. Well, the sacral body is 90% denser than the ala. So if you need to, you can always, especially with the bone corridors of S1 and S2 using the lateral approach, you can put it into the body of the sacrum. You can actually put it to the other ilium if you want to, if you have a long enough screw. And keeping it in the body, don't go too far anteriorly or posteriorly, and keep it in the bone corridor. That makes for a pretty easy revision, provided you have enough bone stock and your trajectory is appropriate.
Great, thanks. Any other questions? Great job, thank you.
Thanks, guys.